Three platforms for peroral cholangioscopy have been described. The classic platform is two-operator mother-baby cholangioscopy, whereby the cholangioscope is inserted through the working channel of a duodenoscope and then into the bile duct. A single-operator platform uses a catheter-based system through a duodenoscope. Finally, there is direct cholangioscopy using perorally inserted ultraslim endoscopes. Ultraslim endoscopes have several advantages. They offer high-resolution CCD chip imaging. They have a 2mm working channel that accepts standard accessories, and they have standard air, water, and suction functions. However, there are limitations. The larger diameter of the scope, twice that of dedicated cholangioscopes, requires a large sphincterotomy to intubate the bile duct. Even with inadequate sphincterotomy, direct intubation of the bile duct is difficult due to the sharply angulated takeoff of the CBD. The main problem is looping in the stomach. Even with a stiff guide wire in place, the more flexible ultraslim endoscope progressively loops in the stomach as the scope is advanced. We have used a hook and pull technique derived from an analogous technique to intubate the ileum during colonoscopy. The first part is the hook maneuver. The bile duct is engaged using extreme tip deflection of the ultraslim endoscope. Retroflexion may be required. The second is the pull maneuver. The endoscope is slowly retracted with counterclockwise rotation. This results in paradoxical advancement of the scope into the bile duct. An ultraslim 5.9mm diameter endoscope with extreme tip deflection up to 210 degrees was used. Here you see how the bile duct opening is hooked with maximum tip deflection. As soon as the bile duct opening is visualized, the scope is retracted, and this advances the scope up into the bile duct, and here the bifurcation is seen. Pulling back the endoscope, we see the takeoff of the cystic duct. In the second case, we have to go into retroflexion to identify the opening to the bile duct. The tip is maximally deflected. We engage the bile duct opening, and once engaged, we pull back the scope with counterclockwise rotation, and this advances it into the bile duct. We can see a few residual stones. Here are our results using the hook and pull technique in 11 patients. This is a very selective group, all with a large bile duct greater than 10 millimeters in diameter. All had an adequate bile duct opening, either from a prior sphincterotomy in 6 cases, a de novo sphincterotomy in 3 cases, and in 2 cases the patients had to undergo an additional balloon dilation to 8 millimeters after a sphincterotomy to achieve an adequate opening. The bile duct intubation rate was 91%, successful in 10 out of the 11 patients. In 1 patient, the scope failed to advance into the duct, although the opening could be engaged. In conclusion, the hook and pull technique enables successful intubation of the bile duct with an ultraslim endoscope with extreme tip deflection without additional accessories. There are, however, limitations of this technique. An adequate sphincterotomy or sphincter ablation is required, and paradoxical advancement with the pull maneuver limits the extent of bile duct intubation, which in general is the upper bile duct.